Good morning, everybody. I think in the interest of time, we should probably get started. I'm going to let Chris Pelt kind of introduce the topic this morning. He reached out to me a few weeks ago about what they've been doing on the joints team in the setting of COVID and moving toward more outpatient joint surgery. And looking forward to hear from you, Chris, and the rest of the team.
Thanks, Andy. Good morning, everybody. So we're going to introduce a program we've been working on for the last several months here at the university. It's not really a novel program in many ways. It's been done in various places throughout the country, but it's an opportunity that I want to introduce to the entire department. And there's not very many avenues for me to present opportunities to the entire department other than through grand rounds. So I figured this would be the best venue. That we're calling the program Heal at Home. And it's essentially a partnership between multiple different disciplines within the university as well as with outside of the university to help care for our patients and get them better care, perhaps in a more expedited fashion to help with our ability to get patients home and out of the inpatient space. Number of drivers behind this, as you might imagine. We have a constantly full hospital, and this is even before COVID. Throw COVID into the mix, and we don't have any beds available in the inn. In addition, there's a lot of payer-based changes that have been happening over the last several years that I want to introduce y'all to, including one that just came about this week and actually affects everybody in the department. Some of this is going to be a little bit of compliance and utilization reviews, so you'll need to bear with me a little bit as we go through some of those details, but they are incredibly important changes that everybody in the department should know about. So with that, I'm going to get started. I'm going to introduce my team that's going to be speaking today real quick. Of course, you guys know me. I want to introduce Peter Weir, who's the Executive Medical Director of Population Health here at UHealth. You guys know Jill as well. She works as our Clinical Manager of Alternative Payment Programs and helps me with a lot of the clinical pathway developments for both the Division of Orthopedic or Division of Adult Reconstruction as well as the department in general, and has been very integral in the development of some of the programs that we're working on to help be able to continue to do surgery in this time. And then I also want to introduce Brent Jones, who's the Chief Operating Officer, maybe even CEO, as well as President of CNS, Community Nursing Services, who is our partner home healthcare agency that the university has partnered with to provide care to our patients out in the community. This is sort of a new arrangement, a new partnership. The university does not own their own home healthcare company like Intermountain or other sort of vertically integrated healthcare systems do, but we have partnered with CNS to help as an extension of the university health, and they have some very outstanding programs, high quality, and commitment to the same level of quality and care that we provide here at the university, which has been really great. So I want to give you guys a little bit of background on what it is that brought this about. We all know that we've admitted patients after surgery routinely for decades. It's often due to the status quo, and I remember Charlie Salzman kind of challenging us on joint replacement. Why do you admit all of these patients? To which I respond, why do you admit ankle replacement patients, but hip and knee replacements? We kind of always have done it that way, so we always continue to do so is one of the answers, quite honestly. There are certainly medical issues, cardiopulmonary issues, pain control, blood loss, fluid shifts, resuscitation, and then any other medical issues that patients may come in with their medical comorbidities. Other patients use the hospital for more rehabilitative reasons, convenience, whether it's a long drive from Bozeman, Montana. They need a little more therapy. They have stairs in their house. They don't have somebody that lives at home with them when they get home to help them when they arrive. They have, social issues, anxiety, fear, and any of those factors keep patients in the hospital as well. And then finally, there's reimbursement and payment factors. And I'm going to spend the next few minutes talking a little bit about those issues, as these are some of the things that have been most in flux and change. And now, instead of just affecting total joint replacement, it affects all of the Department of Orthopedics. And I'll explain what that means in just a second. Outpatient care and total hip and knee replacement is also sort of not new, and in part has been driven by physician ownership and ambulatory surgical centers. And that's not entirely the driving force behind it. But when we look at some of the requests and asks that came about through our academy in the last 5 to 10 years, much of it was as a result of physician ownership in ASCs. And not that it was a perverse incentive in the way that the surgeons are doing the wrong thing by operating in a surgical center. But they have an incentive to push for it. And what they started to identify was that there was a certain cohort of patients that can do very, very well, and they can do it at a lower cost that can be done even in an outpatient hospital-based setting. Whether it's because of the small, nimble environment, it's the ability to control costs on implants and supply chain at a easier level. It eliminates the bloat of the indirect costs of overhead and excessive staffing and covering the expenses of all the sort of non-revenue generating service lines in the hospital setting, et cetera. They can do the same surgery at a significantly lower cost. Many of these cases were done in very highly selected patients. And so it's not a surprise that if you take an athletic young 50-year-old as opposed to a decrepit 75-year-old wheelchair bound with multiple medical comorbidities, diabetes, obesity, and rheumatoid arthritis, there's going to be a difference in their cost, their ability to do these safely in an outpatient environment. But when they start to stratify and look at some of those things, they identify the opportunity that exists. And this is from Becker's ASC, looking at sort of the cost advantages to the healthcare system, and Medicare particularly can benefit from this given the age group we're talking about for joint replacement. And so they started to see that, and they started to allow for these allowances sort of as one-off exceptions early on, and then became more sort of policy driven with major policy changes. So you can see at Becker's ASC, 40% lower cost when joint replacement done as an outpatient in an ambulatory surgical center, lower complications, can be done safely in a Medicare population even, and complications, revisions, readmissions in the ambulatory surgical center versus hospital outpatient setting is improved in the ASCs. Before I move forward much beyond this, I've talked about inpatient and outpatient surgery to this point, and I just want to add this sort of graph. This is from a 2011 presentation that our compliance office gave to this department. So now a decade ago, not much has changed except for where patients are fitting into each of these categories now. But an inpatient admission status is an anticipated length of stay of at least 24 hours, likely greater than 48 hours. And I'm going to tell you that now the definition really is greater than 48 hours, or 2 midnight rule is the driving definition of Medicare. Observation status should be very rarely used, if ever. It's an anticipated length of stay that maybe was an outpatient or bedded outpatient, but something wrong happened. The patient wasn't able to launch for whatever reason. So typically the observation status is reserved for the unexpected, often medical outcomes requiring prolonged stay, not usual care of needing physical therapy, having pain control requirements after a orthopedic surgery, et cetera. That does not count for an observation status. This is somebody that maybe has obstructive sleep apnea, was planned to go home the same day, and their O2 sats post-op weren't as expected. We had to keep them in the hospital overnight, and we were observing on an hour-by-hour basis as opposed to just planning to keep them overnight. And that hour-by-hour basis allows that observation of their medical state, and ultimately they could launch at any point if they became stable. One of the other important factors about observation status is the timer towards inpatient admission resets. It does not count towards the 48 hours or the 2 midnight rule. So if you bring somebody in under observation status for a couple of days because they were failing to launch, and then you need to bring them in as an admission state, Medicare does not count those 2 days towards that inpatient stay. And so now they're going to need to stay another 2 days in order for an inpatient admission status. And then finally, there's bedded outpatient and then true outpatient. There's no difference, actually. Bedded outpatient is simply you would bring somebody into the hospital, but they were in outpatient surgery. It's an overnight stay with a planned next day discharge. They can even stay for 2 days and still be counted as a bedded outpatient. If they didn't stay for 2 midnights and meet medical necessity, the hospital may only be reimbursed at the outpatient state when we were admitting them as an outpatient or a bedded outpatient. So as we go through the rest of this, I want you to keep those 3 categories in mind. So as I mentioned, in 2018, the inpatient only list changed. They removed total knee arthroplasty, laparoscopic prostatectomy, and a couple of other codes, and it did make a significant impact. At that time, they said they were going to halt RAC audits. RAC audits are sort of the auditor that comes around and asks to look through the medical necessity charting and all of the records to say, yep, that was adequate, or that was appropriate, or no, that was not appropriate. Just to remind people how CMS works, we don't have to ask for pre-authorization with CMS. It's too big of a system. The government doesn't have all of these sort of people sitting around reading through charts and wondering if we should pre-authorize or not. They don't have a medical director that we can call for a peer-to-peer. It doesn't work that way. The way it works is they take your word for it on the front end, but on the back end, they audit you. It typically occurs in the 2 to 3 year range after care was provided. And if they do an audit and they find that inappropriate care was performed, or reimbursement was provided for a level of care that was not acceptable, then they do a more in-depth audit, and then they do what's called clawbacks. And so then they'll ask the hospital to give money back that they've already received. And remember, this is 2 or 3 years after the care was provided. So while it can look just fine on the front end and nobody would recognize that there was an issue, 2 or 3 years later, an auditor can come back around and take that money back away from the hospital. They stated that the medical necessity designation could be used when they did this, and that they would leave it up to providers to define who was medically appropriate for inpatient versus outpatient status. And so we went through a very exhaustive effort of creating predictive algorithms, evidence-based risk scores, and care pathways developed to identify who we thought should be still done as inpatient versus outpatient. You might imagine elderly patients, patients with excessive comorbidities, obesity, diabetes, obstructive sleep apnea, et cetera. We kind of included on these kind of risk scores. And we created an evidence-based list. It was a dot phrase in Epic. It was medically documented. It was provided to the auditors. And unlike what they had stated that they were going to suspend RAC audits, what they did not suspend were the quality audits. So there was still a secondary group of private conveners that could send their quality auditors out. And in 2019, they did a retrospective audit of 7 of our total needs. 6 of them were found, despite all of the medical necessity being documented, to not be eligible for an inpatient stay because they did not stay for 2 midnights. They didn't care that they had major medical comorbidities, but if they did not stay for 2 midnights and have all those medical necessities documented, the quality auditors believed that this was not going to be appropriate designation of the inpatient status. As a result, we made some responses. So our utilization review and compliance team kind of said, we're going to just have to change this. We're not willing to risk having audits and clawbacks 2 years from now. They're going to take back, you know, what could be as much as 70 or 80% of our inpatient state statuses to have to give that money back to the government. And so they take a front end downside by putting every patient in the bedded outpatient designation as opposed to an inpatient designation. And then if they stay longer than 2 midnights, flipping them to an inpatient status. And then that's when they would send us a request to say, hey, can you write this order to change the inpatient admission status? But that's a much safer way from a compliance and utilization review perspective to avoid audits and clawbacks at a later time. On the front end, you might miss a few opportunities for making the hospital additional money. The patient's no different in the way they're being cared for. They're staying in the hospital as long as they medically need to, but the hospital gets reimbursed differently when they stay for those greater than 2 midnights. Our surgical care team response was a little bit different. We started changing care pathways via multidisciplinary work groups, and Jill's going to talk about this more. And we made a significant shift to just simply get patients out of the hospital sooner. We already had moved from a 2 to 3 day length of stay to about a 24-hour length of stay. And now what we're doing is saying, with those patients that stayed overnight as a bedded outpatient, can some of those get pushed to go home the day of the surgery? The reimbursement's roughly the same. The expenses are greater if they stay overnight. We're running out of beds, and certainly COVID helped push for that. But that's the other opportunity that existed for us to be able to continue to do the same level of surgery in a very full hospital, and then maybe not have the hospital take a ding on the bedded outpatient reimbursement by using those hospital beds just because we could. So elsewhere, as I mentioned, we decided to put everybody in as a bedded outpatient and then flip them to the inpatient. Well, Chad Kruger and Max Courtney at Rothman were fellows, and so they have been our health policy fellows for the Academy for a couple of years, and they're publishing like crazy about all of these CMS changes. But one of these publications that just came out 2 days ago was that, hey, we can be 98% successful at actually getting reimbursed as an inpatient status, even if they didn't stay 2 midnights. But guys, I'm going to remind you that that's how this works, right? Medicare will pay you if you tell them that they're an inpatient. It's 2 years from now that you're going to have to pay money back. So this publication really doesn't give you a whole lot of enlightenment as to the full process, because it doesn't talk about what the rate of audits are on the back end. There's going to be unintended consequences that resulted from our asking Medicare to start allowing us to do these things as outpatient. First of all, everybody started flipping him to bedded outpatient. People started doing true outpatient, and Medicare pays the hospitals less, and they started to see the advantages of this. Significant reduction in the amount of money that they're having to spend on total hip and knee replacement. So it's the unintended consequences of we're doing a lot more work, but not being reimbursed for it on the professional and our clinical nursing staff and our case managers and our care coordinators. All of that is unreimbursable with this, and all of that work that's being shifted is shifted to that group of patients or that group of personnel. So all that brings us to November of 2020, and this statement was released that the outpatient and prospective physician services payment system had a new final ruling. Medicare is eliminating altogether the inpatient only list. They are phasing it in over 3 years, but as of 2024, the inpatient only list will be gone. So Peter Weir and Jill and I and some others on this working group were kind of talking about, well, that's really interesting, and this certainly is probably gonna push the envelope of people needing to get out of the hospital sooner. Not necessarily if it's a medical necessity for them to stay, but if the reimbursement is changing and patients just aren't defaulting to an inpatient status, there's going to be this in-between phase, just like we went through with joint replacement, where we're either going to keep them long enough that they need to stay and we'll justify it in medical necessity documentation, or they're likely going to start leaving the hospital a little bit earlier. And if they do so, is there a way that we can provide them adequate resource in the outpatient setting? What we didn't realize was that they were going to warp speed those changes to orthopedics. And so instead of just total hip and total knee being removed in 2018 and 2019, now we have 266. This is as of this last week, and I just kind of learned about this yesterday. 266 musculoskeletal related services. I have sent the list to Morgan, and she's going to email the department through the Grand Rounds email list, so that you guys have a list that you can see. What I'm working on is actually trying to find what cases are still on the inpatient only list, which I think will be actually easier to see, because as I read through it last night, shoulder replacement, ankle replacement, hip replacement, revision hip replacement, revision knee replacement, revision shoulder replacement, hindquarter amputations, tumor excisions, spinal fusions, posterior spinal fusions, etc., have all now been removed from the inpatient only list as of last week. Here's a couple of statements from the Secretary of Health on this issue. So finalizing a policy procedures that are removed from the inpatient only list to exempt or postpone the QIO and RAC audits for persistent noncompliance with the 2 midnight rule and for patient status is to be done for the 2 years for the 2020 codes. And for these 2021 changes of all those 266 codes that I just mentioned, until such procedures are more commonly billed in the outpatient setting. So what they're saying is you can continue to just admit them as an inpatient, and we are going to suspend both RAC and QIO audits, which they did not do, as I mentioned, with the total knee changes in 2018. They're going to suspend both of those audits for 2 years for the codes before, and until it's more common to see an outpatient code being billed for all of these new ones that just came about this past week. The Secretary of Health is supposed to be in charge of doing this, and there is no definition of what that threshold, how many procedures that they're seeing, what percentage of posterior spinal fusions that are being billed as an outpatient will create a threshold to start allowing them to audit it. I spoke with Jenny Tuan last night, who's our sort of chief of compliance and utilization review. She's our one of our internal medicine doctors, and spends a lot of time.
Jenny's the best.
Somebody's having fun. So Jenny's going to continue to compile a list, but ultimately the university is probably going to take a very similar stance that we did with total knee arthroplasty and then subsequently total hip arthroplasty, where we default essentially all of our musculoskeletal cases to a bedded outpatient status if they stay longer than 2 midnights, or if they have 1 midnight plus a bunch of medical necessity documentation. Utilization review will identify that and then ask us to flip them to the inpatient admission status. Can mean a significant decrease in financial reimbursement to the hospital, as I mentioned. So the summary really is the RAC and OIG audits won't happen until the secretary gives the okay, after there's been enough outpatient claims to justify the audits of those services. So what does this mean? Essentially, all musculoskeletal and ortho codes that I could identify last night in my cursory review of the list that was sent to me are now off the inpatient only list and will be admitted as a bedded outpatient. The Secretary of Health stated, we believe that the elimination of the inpatient only list, the 2 midnight benchmark, will remain the important metric to help guide when Part A or otherwise an inpatient status is appropriate. My message to our department is you do not need to change the way you care for patients, nor need to rush patients out of the hospital if they are not ready. There's no necessity for you to change the way that you've been caring for a hindquarter amputation patient, as often as we do those, who are probably going to be in the hospital for a week. And I'm not expecting that anybody should be trying to change that to decrease the hospital length of stay to less than 2 days because the hospital was designated bedded outpatient status. Rather, there will be medical necessity documentation of why they're in the hospital and why they need to be there, that the residents already kind of have built into many of their templates, as much as we all hate templates. This is one of the important factors that we need to continue to be cognizant of as we document when people are in the hospital, why are they in the hospital? So as we think about that, and we think about how we can care for patients and the bedded outpatient status and all that, we can imagine there might be opportunities to help extend how we care for patients outside of the hospital itself, whether it's a critically full hospital that we always have here at the University of Utah, or it's patients that are not needing medical acute care, but rather a little additional support, a little therapy, a little nursing, a little hand holding at home, or perhaps for convenience, they fly in from a long ways away and they just don't want to fly back home that same day of their surgery. We might be able to put them in even in a hotel setting and be able to offer them all that level of therapy and nursing care that they might need, but not in a hospital environment. And so with that, I'm going to turn the podium over to Peter Weir, who's going to talk to you just a little bit about a few more of the changes from CMS, including hospital at home, as well as his thoughts on the Heal at Home project that we've been working on. Dr. Weir?
All right, thank you, Dr. Pelt. My main message for you, the takeaway for everyone on the phone, is that we want to be a resource for you within this subject here that we're talking about. And there's 2 things that I want to just go over in the presentation here. One is what hospital at home actually is. And then number 2, to provide a context for a spectrum of services that we're offering that we're calling Heal at Home. And then before I get started, I just one point of clarification. As of April 1st of 2020, Community Nursing Services, CNS, formally merged with the University of Utah. So this isn't like a casual, informal partnership. The University of Utah Health System wholly owns CNS. You can think of it analogous to ARUP. ARUP remains independently branded or co-branded with the U. CNS will remain independently branded, but they are wholly owned by the U. And Brent Jones on the phone reports up to Gordon Crabtree at our hospital. Okay, so first, getting back to the topic. Hospital at home, what is it? It's very simple. It's for patients that meet inpatient criteria. You are literally providing all of their care in the home setting. So you could think of it almost like a virtual ward. In all respects, the patient traditionally, historically would go to the hospital and you're providing acute level services, but you're doing it in the home setting. And the important thing here is what's new is that this was never paid for or reimbursed for by CMS. And that's what's new. So as of November 25th of last year, they announced a way for health systems to apply for a waiver to receive DRG payments for this type of work. Some of you may have heard of Huntsman at Home, and I hope all these at-home things don't confuse people. Huntsman at Home is exactly this, but it has obviously a predilection for taking care of cancer patients, palliative, end-of-life care, that type of thing. In the last 2 years they've been running, they have not received reimbursement from CMS for that work. They received the early waiver and they're going to receive reimbursement going forward. And so this right now, the way we see the opportunity for hospital at home is on the medical side, not necessarily the surgical side, but I'll explain more here in a sec. So if you could advance it one more. Okay, so the way we think of things is on this a spectrum of services that we're calling Heal at Home. And the idea here is to really emphasize this idea of improving the transitions of care that our patients make from our acute care facilities back to home. Off to the left, you've got your historical kind of traditional transition models, which as many of you know, I mean, I trained here at the U. A lot of times the discharge is like you cross your fingers and you say, gosh, I hope this person makes it. But we have very little control over the quality of care that happens, and we have almost zero accountability for what happens to patients when they're at their home. Over to the right is the program I just described, a hospital at home program, where in Jill Erickson's words, literally the University of Utah is following the patient home. And that's not to be creepy, but it's the idea there is that we can ensure the patient safely lands at home. But there's a lot of stuff that you can do in between. So as you move from left to right, the patient acuity is increasing. So over there to the left, there's an opportunity just to generally improve transitions of care patients make out of our hospital. As you move further to the right there, there's an early discharge model. So patients that don't necessarily have high medical needs, but there's something hanging up their discharge. And we're working with the vascular surgery team right now, and they've got patients that have complex wounds, as you guys might imagine. And a lot of times what hangs up the discharge is there's no one at home to make sure that that wound doesn't heal properly. So they keep patients for extra days. That's a great opportunity for us to get the patient out of the hospital earlier than normal. And at the bottom, this is really a really important point, is the value here is that it builds capacity at the hospital. And for folks that do surgery, this is a big deal. So if we can get patients out sooner and increase the number of beds that are available, we can backfill that bed that had the patient that recently was left with a new patient, a new, paying customer, if you will. As we move further to the right on this diagram here, you get into the bedded outpatient category. And that's where I think the hip and knee replacement patients belong. So the idea here is how do we eliminate a bedded outpatient stay completely and get the patient home safely? You can imagine there could be, again, further to the right, a really nice program for patients right out of the ER to be able to go home that are like on the fence as to whether or not they need to get admitted. And then the two programs to the right there are more like hospital at home programs where we have patients with significant acuity that meet inpatient criteria, but we're bringing them back home and we're effectively and safely taking care of them in the home setting. So with that, I'll pause and I'll hand over the reins to our next speaker. And if there's any questions at the end, I'm happy to field them.
Thanks, Peter. So I'm going to introduce Jill Erickson now. She's going to talk a little bit about the pathway development that we did with joint replacement, starting to be expanded to even other of our orthopedic service lines. And I think with the opportunity that exists for other divisions to be able to utilize this heal at home and hospital at home, probably the heal at home concept more, how we might be able to sort of upscale these to other divisions. Go ahead, Jill.
Thank you. As most of you are aware, there's been quite an evolution in the care of total joint patients. When I first started 20 plus years ago, we had no written education and all patients stayed about 5 days. Dr. Dunn used to share stories with me about how patients used to stay 2 and 3 weeks. As I've been working with the team, we've made substantial improvements and additions, but not without significant investment in time and energy and capital for additional staff seen here. As you can see, there's substantially more work to be done ahead of time to get our patients ready for shorter and shorter stays. Our clinical nurses have been critical to this success. In 2015, we succeeded in BPCI, the Medicare bundle. We transitioned patients to their homes instead of care facilities after surgery. And now we have more help from case management and physical therapy and Adam Meyer with anesthesia. And we're working on ways to help joint replacements patients get home prior to even needing a night in the hospital, as Dr. Pelt has explained. Next. Just briefly, this illustrates our last 12 months. The shift from knees coming off the inpatient only list happened last year in 2018, but this represents this year where we saw hips come off the inpatient only list. Of note, when our patients are staying one night in the hospital, they count as outpatient here. and categorized more specifically as bedded out most of the time. So in the beginning here, we were seeing low percentages. Those were the total knees at the bottom, and then this arrow with the inpatient only list arrow is identifying the effect of hips coming off the list. But we started commercial payers almost immediately followed Medicare, and most required patients to start as outpatients first. And then in the months prior to COVID, we were implementing our outpatient pathway, as Dr. Pelt explained, with some success, bringing our outpatient rate up to about 45%, half of which were starting to go home on the same day. And then after the COVID break from surgery in March, you can see our patients were much more amenable to day surgery, as it was their only option in May. And since then, our hospital bed capacity was and remains very tight. Next. While we weren't operating, I feared we weren't going to be allowed to keep our patients overnight. So I started to work through which types of our patients needed a hospital bed compared to those who just may have wanted one. Next. I revisited a list of what a home health company could do for us in a new way, and started to explore ways to meet the needs of more patients. Then come summer, when I was asked to expand our relationship with CNS, we explored which types of patients could use a program like Heal at Home for unmet social needs and minor medical issues. So again, these were patients who are medically fit to be day surgery, but we're asking to stay overnight for a variety of reasons, like Dr. Pelt explained. Next. A key to a program like this is determining what is causing your patients to stay in the hospital longer. And there is a part of your patient population that could discharge sooner with more support at home. We found this to be true with the addition of nursing and therapy visits. Home health CNS could offer other skilled services like maybe an aid or a drain removal. These things are all possible. You just need to think about what is causing your patients to stay in the hospital longer, whether it's a spine patient or shoulder. And then design the best patient experience. I had big dreams, and CNS said, sure, let's do it. Next.
Before we move one more, what I would say is that we went through BPCI, and we went through a radical removal of post-acute care. So SNFs, inpatient facility rehab, as well as home health care are all cost centers in the bundle. And for the large majority of patients, we eliminated the use of home health care. We are not suggesting with this that every patient requires this. What we're suggesting is that these are patients that otherwise were staying in a hospital environment for a prolonged period of time to receive some of the care that now, with lower reimbursement and pressures on getting people out, we can provide them some of the care when appropriate in the outpatient environment or in their home environment.
So in our practice, we have some patients who are healthy enough for day surgery, but, so we hear this, but, and we propose day surgery and they say, but. So we realize that we have a opportunity for two different models for joint replacement patients. On the left, we have the hotel model, and on the right, for patients who live in the area where CNS can cover them, but they are maybe older and nervous. So it's been an awesome opportunity for patients to feel comfortable at home, where I can't go home with them, but I can know that CNS is meeting them at home within an hour or two and checking them in, making sure they're basically tucked in. Instead of being with our nurses on the floor, our patients have the ability to, on the left, go to a local hotel. We use the University Guest House and also Huntsman Patient Family Housing for the patients who live too far away and aren't willing to drive 3, 4, 5, 6 hours on the day of surgery. This has really been helpful. Next. What this means specifically is that if a patient is discharging to a hotel on the day of surgery, a nurse is going to meet them at the hotel, and that is the afternoon or evening of the day of surgery, and then do a fairly abbreviated nurse intake. But basically, many of the goals are that they go over their medications, make sure that they picked up all of their prescriptions and they really actually understand how to take them, and kind of provide reinforcement of our communication in as far as how to take Tylenol scheduled, how to take the anti-inflammatory, to please eat before they take their morning medications. And then they come back again in the morning and ask them how they did overnight, remedy any situations that may have happened. If they didn't use ice, we really need to be doing that. We need to be icing and elevating, teaching them how to do that, reinforcing our communication to them. And then again, in the middle of the morning, physical therapy comes, goes over their exercises, make sure they understand them, and then they will leave from the hotel and drive home that very same day. That was the goal. It doesn't always happen like that, but this was kind of the initial plan. And then almost the same for when patients live locally and go home. They get these same 3 visits: the nurse, night of surgery, nurse and physical therapist the next morning. And then there's the option of either doing our home program, which is video-based, or they can continue with home health if needed. But the goal being, this is just a short-term intervention that CNS is willing to come in for 3-4 visits or so, to make sure that the patient feels like we didn't kick them out. This was all a coordinated effort where we all talk and have great communication. Next. It felt easy to design from my standpoint, but it was been quite labor intensive to implement, with almost all of the heavy lifting done by our case managers, Rochelle and Adrian. They have done an amazing job of identifying the proper patient ahead of time, checking to see if CNS was going to be able to recoup any charges with insurance coverage. And in the beginning, we even did a charity case just to get the pilot program off the ground. But our case managers have been awesome, talking them through this process with preoperative phone calls, and then on the day of surgery, coordinating with the discharging nurse and working with CNS's coordinator to time the discharge so that the CNS staff knows when the patient's going to be getting home, approximately. And then a ton of follow-up documentation and utilization review. It's been quite a journey, but it's really been awesome. And I really owe a big thank you to Rochelle and Adrian for being such integral parts of this program.
We've almost overwhelmed them to the point that we went to the hospital and said, we need another case manager. We've almost lost our case managers that exist, because they were intended to really help with the joint service and the UOC outpatients. And then if you can imagine, as we try to scale this program up, spine or shoulder or foot or any other patients that we start to add on to that now can really overwhelm this amazing team. And again, if you think about the lack of insight that CMS has into how we are changing the care for these patients, we're shifting them from one place to another, but we aren't adding resources or reimbursement to pay for that way of shifting them. And this is the area where we've seen they've done a ton of work and become a breaking point. So with the support of Spencer Steinbach, Tracy Nixon, and others at the hospital, we've been able to post and recruit for an additional case manager to help with the department on this project and similar projects. So our final speaker, I want to introduce Brent Jones, who again is the COO and president of CNS, and has been amazing. I actually met Brent in clinic. He came in as a patient with some knee pain, and it was just a very fortuitous time and moment in our lives that intersected for just all the right reasons. Our conversation, unfortunately, to Brent, went very quickly away from his knee to this partnership and project, and it has been an amazing opportunity to work with him. So I want you to introduce Brent Jones, and he's going to talk a little bit about our early experience with our pilot project in joint patients.
Thank you, Dr. Pelt. The next slide. So we have and by the way, Dr. Pelt, I had shared with him earlier today, my knee feels great. He gave me an injection that day, although it went away from that. I am happy to report that I'm walking and running a little, so thank you, Dr. Pelt. Our partnership with the university, with the ortho group in particular, actually goes back a couple of years, where we formalized an ortho team of therapists and nurses that work directly with Dr. Pelt's group. And that really allowed us an easy transition into this program that we've got now. And what's been good about this is, as you see the team-based approach, you've heard already a lot about team. The case managers and the CNS coordinator have really worked so close together in terms of stepping through the best possible care to be provided and outcomes. And so the key has been for us, and it would be for you as well, the key has been designated teams, designated CNS coordinator, where you know that one person that you call and coordinates all of that care instead of a number of other people. So we've enjoyed that approach, and it's worked, I think, extremely well. You do the next slide. Some of the outcomes that we wanted to share with you today, and I need to just, maybe from a personal standpoint, I wanted to go on the first visit. And so I had an opportunity to go on the first patient that came onto our program, and they went into the hotel. And that was a good learning experience. I was there with the nurse. We walked in with them into the hotel. I got to see the big husky dog, the hamster, everything that is entailed in that. But it was so helpful because that's what our nurses, that's what our therapists, that's what they deal with on a routine basis. And so I got firsthand insight and knowledge of this. And I think it was very helpful for me and our team as we kind of step forward into it. But you can see we've had 2 patients that have went to the hotel. The others have all went home. No readmission visits, which has been critical. No ED return visits, which is obviously critical for us. Avoiding those hospital beds, all of them. There was one that we did not, just because you can see down on the bottom, there was just pain and the oxygen levels were low. CNS, by the way, we do the home health, we do hospice, we do respiratory, we do oxygen, DME, pharmacy. So we're really, we can take care of a lot of the needs that they have, most of the needs once they leave the hospital. You can see the RN and the PT visits, the number that we had scheduled. And again, what's critical about working as a team is we know exactly what Dr. Pelt wants for his patients, and the exact protocol that's written. And so our nurses and our therapists follow those with exactness on every visit. So you can see these are the visits that we have incurred at CNS on the RN and the therapy visits as we have gone through this. But it's been a wonderful experience. These are some of the 3 of the comments that have come back from the 5 or 6 patients that we've had. They'd recommend, plan on using, and then a great experience. And I even heard somebody say, and I'd listened to the recording, that it was a grand experience as well. And boy, if we can get that great grand experience from all of us and they would do it again, that's what we want. So it's really been a privilege to work with the university team, the ortho team. Dr. Pelt and Jill has been just phenomenal in helping us as we've stepped through this. So we've appreciated it.
All right, thanks, Brent. So that concludes our presentation on it. We have about 10 minutes available. The reason that we're presenting this today is because things are changing rapidly. CMS, as much as we may hate to admit it, really does help dictate or drive change in healthcare. And as Jill mentioned earlier, our private payers very closely mirror what CMS decisions are. And so when they choose to remove an inpatient only list or remove codes from it, or change reimbursement rates or RVUs or any of those things that are also happening, I'm not even going to have time to get into those today. Private payers tend to follow as well. So I've mentioned how changes to the inpatient only list exist, bedded outpatient status, et cetera. I've talked about how we've kind of accelerated discharges, and I'm not suggesting that everybody in the department has to do that, but you're going to have patients that are going to fall into that window that might have an opportunity to have better resources available to them and get out of the hospital at a sooner time point. That could be a benefit to the hospital if we can open up more beds. It could be a financial benefit to the hospital if we don't use inpatient beds unnecessarily for a bedded outpatient that truly is a bedded outpatient type of patient. We can take better care of patients perhaps in an extended way, not just having them in our facility doors with a partner, as we've mentioned with CNS, that can be an extension. As Dr. Weir mentioned, the hospital at home is probably not going to be an orthopedics thing. I can't imagine a surgery where we think that they're going to be in their home as an inpatient. It doesn't make a lot of sense. This makes sense to me for maybe some of these long-term COVID patients, that are in our hospital for a month after COVID with respiratory failure, liver failure, kidney issues, et cetera, cancer patients, et cetera. But for us, this heal at home, I think, is a true opportunity. So we want to open this up to discussion or questions. The reason to present it is because we think that this can be an opportunity for not just joint replacement, but for the department to start taking advantage of. We want to be cognizant a little bit. I know Rochelle's probably watching and already reeling, but we're bringing another case manager in to try to help with some of this. And not every patient is going to need this, but it is an opportunity that it's existing for our department, I think, to care for patients in a different way, a little bit of a paradigm shift, but in a better way in many ways in my mind. Looks like there's some chats. Comment from Dr. Saltzman. Go ahead, sir.
First, thank you. Outstanding presentations. Thank you, Chris and Jill, Peter, and Brent, for all the work you're doing and have done on this. I'll make a comment and a suggestion. The comment is this evolution will not stop. The direction that was set 10 years ago will continue, and it will continue for lots of cultural and financial reasons. And so we need to, my view is, as a department, we need to be very strategic in thinking about where we are in 1, 3, and 5 years with patient care as a department. I think we're going to need a group that's expanded. I think you put your finger right on it, Chris. We're going to need a group that's expanded from the core group here to look at all parts of what we do and think about where we want to be in a year for each of those groups in 3 years and 5 years, and to challenge you and everyone to think about what is it going to look like in 5 years for a patient? How much are we going to rely on in-person visits? How much are we going to rely on Zoom, which obviously has had an epochal change with COVID, changing all of our lives? And how much can we rely on other modalities? Chris Pelt's had a lot of interest in other modalities. And I think we need, as a group, to be in front of this, not behind it. So I think I'll put together, with the help of the chiefs, sort of a close study group for strategic planning around this, because you put your finger right on one of the major issues that's sort of out of control right now for our department, with the preparing for care after surgery.
Yeah, I think that's a great point. Just going back in joint replacement, we used to admit patient to the hospital and have no plan for their discharge. So case management would start seeing them on post-operative day 1. That's why their hospital length of stay was 3-4 days. So when we got Rochelle's position moved to the USC to start planning for people to leave the hospital before they even have surgery, it's an elective planned surgery. So why are we waiting until after their surgery? So I think all of us can be thinking about those kind of concepts in our practices. Brick Martin asked a question: is there evidence that increasing outpatient surgery leads to increased harms to patients? And I could say that there's, you know, hundreds of papers that have been published, at least in the last 5 years, about the safety of moving these kind of cases to the outpatient environment. That said, you have to look closely at how they're doing it. And many of them are very risk stratified, very highly selected patient cohorts that are being done in either an ASC or an outpatient environment. So I would say that there's evidence that it is safe. There are obviously some patients that these are just not going to be acceptable for. And that's what I want to make sure we don't try to push an envelope by some sort of designation of status that exists. If it's appropriate medically for a patient to be admitted to the hospital, we absolutely should be taking care of them in the hospital. Don't treat patients differently or you know, with lesser quality because some designation. We can justify it, but that's why documentation is so important. Other questions? Feel free to chat or post it in the, or even unmute if you want. We have 4 minutes left. Ah, it's all perfectly clear. All right, well, I'll give you the 4 minutes back to your day. Thanks everyone for your attention. I hope this was helpful, and feel free to send us an email, ask us a question in the hallway, or reach out to your friendly case manager when we have our next one coming in. Thanks everybody.
Thank you.
Thank you.